Hello, my name is Dr. Sid Campbell, Chief Medical Officer at Health Services for Children with Special Needs. I'd like to welcome you to this continuing medical education program on healthcare transition. HSCSN is a Medicaid managed care organization that serves children and young adults eligible for the Supplemental Security Income Program. Our plan provides comprehensive health services and individualized care management to over 5,400 children and young adults with special health care needs in Washington, D.C. HSCSN is the CME sponsor of this learning activity. HSCSN is accredited by MedChi, the Maryland State Medical Society, to provide continuing education to physicians. HSCSN designates this activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should only claim credit commensurate with the extent of their participation in the activity. We thank you for taking the time to view this online CME course and for thinking about improving transition services in your practice. The objectives of the Healthcare Transition Educational Program are: 1. Learn the core elements of implementing the new clinical report and algorithm jointly developed by the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians to improve healthcare transition for youth and families. 2. Learn about quality improvement tools, strategies, and resources used by pediatric, family medicine, and internal medicine practices participating in the DC Healthcare Transition Learning Collaborative and how to implement them in practice. 3. Become familiar with resources for transition support. The course is divided into 2 segments. The first segment is a presentation by Dr. Patience White, a pediatrician and internist and a nationally known expert on transition. She will provide an overview of the clinical recommendations on healthcare transition. She will also describe the DC Learning Collaborative, a group that is using a quality improvement approach to improving transition services for youth with special healthcare needs in Washington, D.C. The second segment is a panel presentation with 5 physician leaders participating in the DC Learning Collaborative. Each panelist will briefly present on the 6 core elements of transition. They will discuss the strategies and challenges they have experienced in implementing the core elements in pediatric and adult primary care practices. A short quiz will follow the 2 program segments. 1 CME credit will be awarded upon successful completion of the quiz. We hope that you have enjoyed the CME program and thank you again for your participation.
Transitions are something that everybody is aware of and certainly have become a popular thing thinking about in healthcare, but they really haven't paid a lot of attention to that transition from one pediatric system to the adult system. So it's really warms my heart that so many people are here tonight. And I have a wonderful team that I've been working with here in Washington, D.C. that we'll be talking about as we go forward. Just to remind you, we have no disclosures here. And the learning objectives tonight, we really hope that you'll get a sense of the core elements for implementing the new clinical report and algorithm that, as you've heard, is developed by the AAP, the AFP, and the ACP to improve healthcare transition. And really, this is an approach to transition that's a quality improvement methodology. And I hope you'll get a sense of some of the tools and resources that are going to be used by our learning collaborative that are available to you as you think about doing some kind of transition work in your practice or in your systems. And finally, we certainly have a lot of good local resources here, and you'll have that in your packets. So this is this wonderful bridge to the future here. I hope it will be less foggy by the time we're done tonight when we're thinking about transitioning from pediatric to adult health care here. I want you just to reflect briefly on these questions. What do you remember about your transition, or if you have a young adult or adolescent in in your household or you're working with? When did you leave, or did they leave the pediatrician and move to an adult provider? Was it continuous care, or was it something that just happened, right? You just left and then you showed up in the system sometimes later, which actually is the norm out there for most people. They leave their pediatrician somewhere around the ages of 10 to 18 or so, and then men show up much later, sometimes around 50 or 60, and women tend to stick a little closer to the healthcare system because they need birth control and having children. So that's sort of the way it's happened, but we're actually asking something very different here. So was that care of that young person you're thinking about continuous, or was there a gap we just discussed? Or did they leave actively? Was it a planned process, or was it just sort of, gosh, I gotta leave now and I'm out there? So who are we talking about here? This is a wonderful definition by the Bureau of Maternal and Child Health. It is really, I think, a very inclusive one. So they're talking about children and youth who have or are at increased risk for a chronic physical, developmental, behavioral, or emotional condition. Youth. And when you look at the numbers here nationally and the District of Columbia, you can see that the proportion of youth with special health care needs ages 12 to 17 in the district are about 22%, or about 8,000 youth. Now we also have many youth above the age of 17 who haven't transitioned necessarily. So this number is probably much larger than that. And you compare it to the 4.5 million youth in the United States. You can see they break down with functional limitations or more chronic conditions, and with emotional, behavioral, or developmental conditions here. So what is healthcare transition when we're talking about it? It's a deliberate process of moving seamlessly from really pediatrics or child-oriented healthcare to adult-oriented healthcare. It has lots of components. We're talking about self-determination, person-centered planning, preparation for adult healthcare, work independence, and inclusion in community life. We're really focusing mainly on preparation for adult health care and making that transfer from one system to the other. But what applies to all is that we need to start early across this bridge. So what does the data tell us a little bit? What do youth say they want in transition? Now globally, they talk a lot about certain priorities, and I've actually been in many groups where we did focus groups, and whether it's been in European developed countries or in the United States, and almost all of them get the issue that they need to make some money. They'd like to work. That's important. Note, healthcare transition isn't number one on their radar screen here, right? Number two, independent living skills. Now, where is transition to adult healthcare here? Well, here you go. You're getting close as we're getting warmer. Finding quality medical care is extremely important, particularly what to do in an emergency. They talk a lot about that. What am I going to do? Legal rights, protecting themselves from crime, and obtaining financing for school. So I'm sorry, transitioning isn't top of their list, but it's something we need to help them with to be sure that they can do a career, can live independently, have their legal rights, and protect themselves from crime, and obviously go to school and get a good job. So what proportion of parents report receiving adequate transition support here? This is, again, data from 2009, 2010, and you can see here that about 34% in DC actually feel they receive the services needed. That's about 2,000. And across the United States, it isn't that much better. It's about 1.7 million that actually feel they get adequate transition services. Women seem to do better than men in this a little bit. Clearly, if you are of color, you'd have a worse chance of getting these services. If you're publicly insured, it's not as good as having private insurance. And clearly, the medical home, which we all know is really great for young people and to live well and have quality health care, it's better if you have a medical home than without a medical home in this process. Now, are youth prepared? There are many studies. I just love this one in particular. This is done in 2011, and this is a series of 20 young people on dialysis with renal disease in their 20s. And as you can see here, it's sort of amazing. How many of them came with an introduction? Well, 75%. They know their meds. It's beginning to drop here, about 45%. Knowing their disease. They weren't asked what kind of kidney disease they had. They said, what's your problem? All right? And a lot of them didn't know. And who is asking the questions here? And why are they in the room? That's the question here. So parents are asking the questions, and the youth aren't. And clearly, many of them that have made the transition felt it was difficult. So we have a lot of work to do as we're thinking about this issue. Now, what do pediatric and adult physicians say? There have been lots of surveys. And this is sort of a grid to get us to be thinking about what the adult healthcare provider would like and what the pediatric providers say they offer. I think this is important here. Let's look at the pediatric column here. As you can see, about a little less than half state that they actually help youth with a referral. About 27% create a portable medical record or something that they can hand off to another physician. About 23% say they will offer consultative support for that adult provider as they're trying to make this transition. But what's striking here is about 80% find it difficult to break that bond. Pediatricians have done a fabulous job, and it's hard. It's like parents. It's hard to send them off to college. It's really hard to send them off into that adult environment. When you look across at what the adult healthcare provider would like, it's actually what any physician would like. They want an initial and ongoing communication with their previous providers. And they'd love to have a medical history. And clearly, many of the youth that are being transitioned into the adult environment have diseases adults have never seen. Some of the genetic diseases and a variety of things. So the adults would really like a fact sheet or something, some advice, some help. You know a lot about these diseases in the pediatric arena. Not so many of the adults have ever thought about some of these diseases. After all, they're just beginning to survive in the last 20 years to grow up into adulthood. Now, also, the pediatric group, 84% they lack knowledge about the condition. They're admitting these things. 33% of the pediatricians didn't ever discuss the concept of consent at the age of 18, right? And 12% of pediatricians created some kind of individual transition plan. Now you can see, adults really want youth to be ready to make those health decisions. After all, it's just that physician and that person in the adult environment. The family doesn't play a role unless there are cognitive challenges here. They really need them to have disease management skills, know their disease, their meds, make appointments, those kinds of things. Both acknowledge the challenge of creating a good medical home. Financing is always an issue when you're having to spend more time to help somebody to make these kinds of transitions. Infrastructure, who can help me with this? Clearly, knowledge transfer is important here, and everybody knows the adult provider system is under tremendous pressure, potentially with many more adults coming into the healthcare system as well. So here you go. Now you're really confused. And you say, well, what am I going to do here? Thank you so much for all that data. So let's think a little bit about what's been going on in transition. So there has been a lot of effort. There's been probably 10 or 20 years worth of effort thinking about this. This is a hard subject. We've developed a patchwork of pediatric clinics, mostly in the university subspecialty setting. So there's not too much much effort been able to be created in the primary care setting. The problem is it hasn't spread, right? So the national data continue to reveal little progress is really made in transition from the pediatric adult health care in the past decade. So 4 years ago, this has really become a hot issue in the American Academy of Pediatrics. It was voted in the top 10 priorities to really think about this. After all, many of the pediatric specialists and pediatricians are handling people in their mid-20s and 30s. I think they're beginning to say, we need to find a way to make this happen smoothly that I'm confident in. And you've seen these surveys. We've done now many surveys. I just showed you sort of the summary that reveal the need for more information. So when we thought about this around 2 or 3 years ago, we realized the pediatricians and adult healthcare providers were requesting tools and concrete methods and ways to think about this. And what was developed really 2 years ago, we pulled together an expert group and developed a clinical report that this is what we're talking about tonight, which is a practical, detailed guidance using sort of a step-by-step algorithm and integrating transition planning into the adult medical home and ongoing chronic care management, and providing guidance for financial support as we think about it. And this is the actual paper that she mentioned earlier that came out in Pediatrics in July of 2011. So the clinical report actually targets all youth. It's algorithmic structure. You have a copy that you can look at in your handout. It's branching for youth with special healthcare needs, application for primary and subspecialty practices. There's a structure for training and continuing education and research. It does provide explicit practice-based guidance throughout this process and extends to the transfer into the adult environment. Here's just a picture of it. As you can see, that second row is really talking about the actual year and what you should be thinking about in terms of happening in that clinical visit when they're 12 and 14, and then thinking about what you need to discuss. And then if there is a youth with a special health care need, there's an algorithm component to that as well. So these are transition visits that are recommended at age 12, talking about some of the tools we're going to be mentioning. Policy at 14, really planning and getting this going. At 16, discussing the youth and parental expectations. And then at age 18, this is the crux here. Even if they don't leave the pediatric environment, is trying to move them to an adult model of care, which really says privacy is important unless you need guardianship, and that the parents should be out of the room. So the youth begins in the umbrella, and the safety of their pediatric providers begin to spread their wings and try it out. Because it's very hard to send them to a new provider and have everybody leave the room at once without any support structure. And obviously, age 18 to 22. There is a National Healthcare Transition Center that's got transition. It's MCHB funded resource center. It's responsible for developing transition tools. I commend you to really look at the website. They have a lot of wonderful information. And they really developed, along with us in the District of Columbia, the concept that perhaps we ought to look at this process as a quality improvement and develop learning collaboratives. The methodology is really the National Initiative for Children's Healthcare Quality, and pioneered by the Institute of Healthcare Improvement. They did this around the medical home. And you develop an expert panel that really guides these learning collaboratives, and you really bring the physicians as well as the allied health and the parents together. They meet in a series of meetings and talk through all the different issues that need to be thought of as you're moving from one system to the other. And there are learning collaboratives now in DC, Denver, Boston, and New Hampshire. And what are we talking about? You have a copy of the 6 core elements in front of you. They're outlined for both pediatric and internal medicine practices, but we're talking about preparation, which means you're thinking about a transition policy, a registry, thinking about readiness skills checklist, planning, be sure you're moving into a planning mode where you have an action plan that's developed from your skills checklist, a portable medical summary that grows as they move and it's ready to be part of the transfer checklist and things that go to the internal medicine physician or the family practice physician, and clearly condition-specific fact sheets. And then finally, it's that moment of transfer. Now, a lot of people think transfer is transition. No, we're talking about a process here. The transfer is really that culmination of all the work that everybody's done, but the work isn't over. The adult provider really has a lot of work to do as well to make sure they really do get into the whole ability of managing their disease. So we're talking about a transfer checklist. I'll show you quickly that. Availability of the pediatrician to be asked, how am I going to do this? Tell me about this young person so that we know the transfer will go smoothly, and having direct communication. This is just giving you an example of the transfer checklist. You have it in your handout, but it's really, we all know Atul Gawande was very smart and realized that the best thing to get something done is to have a checklist. And here's that checklist that really says we're ready to go. Everything is ready for the adult provider, and the adult provider similarly here has a checklist to say, I have everything I need in that transfer care package. I feel confident that I can provide the care that this young person needs to go forward with this. Now, the learning collaboratives for healthcare transition are a little bit different than the ones in the past. Their unique features are that you have to have sort of dyads, pediatric and adult practices that are really bridging systems. Family medicine has done this all along, but the rest of us are catching up and bridging this kind of practice systems. Involvement of care coordinators, which is a big part of the medical home. Consumer involvement, really making sure we have a young adult and a family involved as you're thinking about working together and working across these organizations and systems to improve care. Now, the beauty of a learning collaborative, not all bridges look alike, as you can see here. Each learning collaborative, each group really thought through how to use these tools and then adapted them to what would work best for their system and their practice. DC really is a national transition model. It has been funded by the DC Department of Health, and as you see here, operated by the National Alliance to Advance Adolescent Health. And we have 5 wonderful sites. You're going to hear from them tonight. As you can see, from George Washington, Howard, Children's National Medical Center, as well as Adams Morgan Clinic at Children's and Georgetown Adolescent Clinic. So they've been wonderful to work with. They're working very, very hard. So their job was to incorporate 6 core elements. You can see them here. Develop a policy, you'll hear about this. Develop a registry. Think about the planning tools and try them out. And utilize an adult model of care at 18 and think about what that means in the pediatric setting, if cognitively appropriate, and then obviously transferring. I want to give you a sense there is a transition index here, and we're hoping, as with the medical home index, these will become quality measures over time. We're really testing them. And you can see them here, the indicator. There's really 4 levels of whether your team is doing this partially or completely. So as you look at this, and we're going to look at how these teams were when they started and where they are after 9 months. Our goal was to have 30% improvement in 9 months in many of these indicators. You can see that the policy, obviously knowledge and skills, is 2. 3 is looking at transitioning youth and young adults through registries, readiness assessments, transition plans, and then transfer. So what's a wonderful thing is they've done incredibly well. You can see the blue bars were where they started, and number 1 really means in a policy that lots of people were doing whatever they felt like and there wasn't any general consensus, right, in the practice or in the system. And you see many of them are moving very rapidly to making this something that everybody understands what to do. So we're very thrilled, and they deserve a lot of credit for doing the hard work. So I just let you know where we're headed, and then we're going to have a chance for some questions. So we want to build a sustained transition system improvement and accelerate the adoption of best practices here in the District of Columbia. We are the leaders. We're 18 months ahead of Harvard and Boston and Denver, and we should be proud of that. And we've really set up a lot of these tools for people to try out. So we're really looking to disseminate and embed transition processes, obviously into larger pediatric and adult medical home practices and specialty clinics, expand transition training opportunities, work with public and private insurers as we think about this process going forward, develop youth and parent leadership on transition and education opportunities to really build that awareness and have the consumer really an active part of this process. We want the youth really to be a part and drive this as well. And also complete more research to find out the most effective approaches for better outcomes. So I'm really thrilled that you're all here. I want to thank you. I'm happy to take any questions now, and then we'll get the panel folks up here to tell you what they've done so well at. So thank you very much.
Good evening. So I'll be starting with April. I'll start from the pediatric perspective or adolescent medicine perspective about developing a healthcare transition policy. So from our perspective, why it was important to have a transition policy was to build consensus among our practice, to address fairness. A lot of times there are patients who are asked to transfer sooner than others, and sometimes this can be perceived as unfair. meeting expectations, so setting clear expectations and meeting them. And a hard timeline so people knew what to expect. This is our policy that we developed at the Adolescent Health Center at Children's National. And I will read it to you. So the Adolescent Health Center is committed to helping all of our patients make a smooth transition from pediatric to adult health care. This process requires working with you to plan and prepare your transition starting around your 14th birthday. According to hospital policy, all patients are expected to transition from children's to an adult primary care medical home by age 22 years. We will provide you with ongoing resources to help you take increasing responsibility for your own health care to the best of your abilities. We are also able to help you select a medical provider that participates with your insurance, to organize your medical records, and to support all other aspects of planning for this important transition as part of lifelong preparation for successful and well adult life. So how do we develop our policy? Well, we sat down as our team for the Learning Collaborative, which included me, Teresa Graves, who's our lead nurse, and a patient consumer. And we generated a list of things that we felt were important to include, including the things that were in the policy statement that Dr. White just discussed. We wrote a draft collaboratively. As part of the Learning Collaborative, they provided a template and several different examples of policies. We shared this with other care team members, multiple providers, administrators, patients' families. We revised it several times based on their feedback. And then we came to a consensus that basically this is as good as we're going to get it. And posted it in the waiting room check-in windows a couple weeks ago, and made packets, and it's available in the provider conference room to distribute. The challenges really have been, first of all, sort of getting our team consensus, especially regarding age limits. Also getting honest, thoughtful, and constructive feedback from youth and parents was a little bit challenging. Everyone sort of said, oh, this is awesome. And so we had to come up with ways to say, why don't you underline words that are difficult to understand, or circle things that you really like? And then that way we were able to get more honest feedback. It was also challenging to post it and have it distributed systematically. We're still working on that. Ideally, this should go to all youth, not just those with special health care needs, or those 18 and older. Basically, everyone should kind of know what the roadmap is going to be. And then, getting everyone in the team to feel like the policy makes sense based on their own philosophies, which are all very respectable. But the benefits really have been that the families who have received the policy, said that they were grateful for the information. They wish they'd had it when their older children were transitioning. And now, everyone theoretically should really understand what's expected in the transition process and over what time frame this process is going to occur.
And our policy really centered around that young adult as the sole decision maker. That's the thing we struggled with the most as patients transitioned in, getting the parent out of the room, as you heard Dr. White say. So I will walk through this. We thought this was important, first and foremost, because it's the law. We all have to abide by HIPAA, and we wanted to make sure that we were all following that to the letter. And we also felt that it would help clarify things for our patients and their families so that they would know what to expect. And we really wanted to start empowering our patients to make these decisions for themselves and to become the sole decision maker and build self-confidence and competence around their medical decisions. And finally, we really wanted to make sure that we were speaking with one voice, that it wasn't just the provider saying this, but the call center when the patients called in, and when parents called to try to schedule appointments, we were consistent in saying, no, your son or daughter needs to call, and that everybody was on the same page. I won't read this policy to you, but I will tell you that we have a HIPAA document that's about 7 pages long at the Medical Faculty Associates, and we didn't think that that would be a useful document for this process. So using some of the templates that Lisa mentioned, we really tried to condense our policy down to a 1-page paper. And this first paragraph talks about how we'd like the information to flow, that we want to work to coordinate care. We need the information, and we'll work with the young adult to coordinate their transition, work with them and their pediatrician. The second part really has to deal with that young adult as sole decision maker, and what does that mean? And we put a sentence in here, as you'll see about halfway down, where we say, this means we do not discuss any aspect of your care with anyone else unless you specifically ask that we do. We showed this to our patients, I showed it around to my colleagues, and we felt that this clarifying statement was actually pretty important, and patients liked it when we gave it to them. They said, oh good, this means you can't talk to my mom about this. But we also recognize that collaborative decision-making is very important. I think we all probably make medical decisions with advice and input from our families, and we certainly don't want to exclude parents in that process, but we want to be very clear that we don't do that without signed formal consent. And so we came up with, or we developed consent documents as well that allowed these youth and young adults to specifically say, you may talk to, list the name, and be very clear about when that's appropriate. We did this, as I mentioned, several doctors, our team, a social worker. We field tested it like Lisa mentioned. We've revised it, and we're in the process of sharing it with the staff. I will tell you that we did hit a speed bump when we sent it to our risk management. They took a long time going over it, and we went back and forth several times, but we finally got something that we both were happy with. And we have disseminated it in our clinics, and again to all of our staff, call center, and so forth. The challenges have really been when these issues have not been brought up. This is the first time patients are hearing it, and that's can be a bit of a challenging discussion, as I think you probably all are aware. Many parents don't understand this. It comes as quite a shock to them, and so that's one of the difficult things to navigate. And then there's the patient. Some 18-year-olds are not terribly mature, and so really working with them, I think that's not news to any of you here either. But the benefits really have been, I think patients like this, it really sets the expectations very clearly. I know the doctors like it. They can point to this policy and say, see, Mom, this is what I have to follow, and that really helps us with these discussions. And I think eventually it's going to help with adherence and outcomes as these young adults really start taking control and making those medical decisions.
So I will be discussing the transition registry and the readiness assessment, which are two tools that we recommend that you use in this process of creating a transition policy and program at your office. The reason why the registry is important is because it creates a paper or an electronic database to help document or track youth with special health care needs. As my colleague stated earlier, the goal is not just to do that for youth with special health care needs, but all youth as they transition through the process. It also allows you to systematically identify youth and young adults as far as what their needs are in reference to transition. Do they need to know how to make an appointment? Do they need to know how to get to the appointments? Do they need to know how to do prescription refills? It allows you to go through that process systematically. And it also helps you to individualize patients' visits consistent with the transitional clinical recommendations. So what is our plan? What are we going to do? What are your deficits, and how are we going to meet those needs? Excuse me. So the implementation strategies from the standpoint of family medicine, what we did was we identified youth between the ages of 12 and 17, as well as young adults between the ages of 18 and 26. And so that's a little bit different as far as the caveats are concerned if you are in a pediatric practice. Your goal might be to do that between the ages of 12 and 18, and then the adult practices the young adult. But because we're family medicine, we had the great luxury of being able to do that for both. As far as the registry is concerned, we basically created a database, which was a registry, where we went through patients' information as far as charts. And the way that we identified those patients was when they came into the office, we had our coordination care manager, Ms. Blasilda Lycott, who's not here tonight, to identify patients that met our needs or that met the requirements, which was their age, and then we were able to populate them into our registry. So of course the registry, some of the items on the registry would be the patient's name, their date of birth, their diagnoses, what's the severity of their diagnoses, whether or not they have insurance through HSCSN, who their primary care provider is, is at that time, when was the first contact date, and then additionally you would have the subsequent dates of their contact as well. When were they last seen at the office? When was the upcoming appointment dates? Whether or not the patient had gotten a transition policy handed to them and discussed. And then also, was the transition visit done with that patient, as well as a readiness assessment, and then what is the action plan to come? So those were the categories that we had in our registry. It also allows a physician to populate and it's a dynamic process. So to populate the registry and then go back to the registry as far as updating the information when you have subsequent visits and things like that. And that allows you to track their progress. Now, the challenges, in healthcare, our goal is to go towards electronic medical record. So it seems kind of redundant or kind of backpedaling if you all of a sudden have all of these papers that you have to fill out. So one of the challenges is to incorporate the registry into the electronic medical record that you use. So I know myself and April, we use MFA. The TouchWorks program, and then different offices use different programs. So that has been a challenge as far as getting the registry into our electronic medical record. Also, to populate, one of the other challenges is populating the registry from different sources. So from our standpoint is that we run a family medicine residency program. So you have different people who will offer that information as far as getting the information into the registry itself. Also, using the registry as a dynamic tool, so not just putting the patient's information in there when they first come in, but also being able to go back and put that information, updating the information. Was the readiness assessment done? What is the action plan at this point in time? When was the subsequent visit? That type of thing. So being able to go back to the registry and continue to update it. Now, some of the benefits is that it allows us to identify youth and young adults in our practice, and it allows us to even look at what their status is as far as transition is concerned. Where are they? Do they already know how to do a prescription? Do they already know about their diagnoses, that type of thing? So it allows us to systematically look at the youth and also figure out what their action plan is, what needs they have in regards to transition. It also allows us to organize our youth into one database so that we can keep track of our youth in regards to what their transition needs are. It also allows us to ensure that youth or families receive recommended transition support services. So it's basically like a checks and balances type of operation there. Now, the next thing that I'm going to talk about is the readiness assessment, and I smile because one of the people on our team is Dr. Luis Nunez, and he is a third-year family medicine resident, well, soon to be third year, and will be the chief next year, and one of the chiefs in our programs, and he was very instrumental with the readiness assessment. But at any rate, the readiness assessment, in our situation, is a 21-item assessment where it's basically a survey that the youth goes through and answers questions in regards to what they can do, what they feel like they need to learn how to do, and or if they don't know how to do it at all, who is going to be the person that does this for them. It allows us to look at different things that the youth may need help with doing. And then also, why it's important is that it's a self-assessment for the youth, and it also allows the physician or the nurse or whomever is giving the assessment, it allows us to look at what are the deficits and actually what are the things that the youth already knows how to do. So it's no longer a cloud that no one knows about. Now we are aware of what the youth needs to learn how to do. And so, as I stated, it's a 21-item scale. There's a variety of questions. So one question may be, do you know how to do prescription refills, or are you able to get prescription refills if you're asked to? Do you know how to make it to your appointment? Do you know what your diagnosis is? And then what to do in an emergency. Those are just a sampling of some of the things that are on our readiness assessment. And then the patient rates himself as either, yes, I am able to do this, I want to know how to do this, I need to learn how to do this, or someone else will have to do this for me. And then we go from there. Now, the transition readiness assessment allows you then to create an action plan, which someone else will talk about. But in regards to our experience with it, as far as the transition readiness assessment is concerned, some challenges have been addressing a range of patient education levels to make sure that the readiness assessment is understandable all on one. And that, I would say, has been one of the challenges in even creating a policy, making sure that everyone can understand it. Another challenge would be to identify and practice the practice process for how all of the youth will get the readiness assessment, how it will be filled out and completed, and then who will look at the readiness assessment afterwards and then act upon it. In our situation, the coordination care manager distributes it, and then the patient is to give it back to the physician, and the physician is to go over it and then make a plan in regards to that. One of the other challenges, which is, I feel like I'm beating a dead horse now, is being able to incorporate the readiness assessment into the EMR so that you're not having redundant work as far as paper and EMR at the same time. And then even time constraints. But I would say one way to get around that is the patient, and at least in our practice, the patient is given that by the coordination care manager when they come in. And so they're filling it out as they're waiting for the physician to come into the room. Some of the benefits is that, one of the benefits is that it allows the practitioner to assess the patient's transition status. Where exactly is the patient? Where do we need to go from here? It also allows the patient to do a self-assessment. It solicits involvement from the patients and families and understanding their healthcare readiness and how they will take ownership for their own healthcare. It also allows the practitioners to make a plan based on the assessment, which I talked about earlier. And it allows us as practitioners to improve our management of the patient's chronic conditions and also their independence of their own care.
Alrighty. Good evening. I'm going to talk about the core element number 4, the portable medical summary. And why is this important? So this is trying to ensure that medical information is up to date and giving us the ability to consolidate and communicate with clear information, and that can be shared via email, fax, phone, in person, giving it to our patients, or across health systems, whether it's to Healthcare for Special Needs or to Department of Disability Services or the Department of Mental Health. And this facilitates the transition of care from the pediatric and adolescent to the adult health care practices. So our portable medical summary at Georgetown, our implementation strategy. So first we tried to figure out what we wanted to be in the portable medical summary. And of course we wanted some basic patient personal and contact information, and so that if it was given a copy to a new provider, they'd be able to know if there was a guardian involved, who that person was, how to reach that patient, who their other medical providers are. So for our patients with special needs, they may have multiple subspecialty care, and having one resource that states that which is their kidney doctor, who's their cardiologist, et cetera. As well as having any emergency contact information. Diagnoses and problem lists for some of our patients, that may be limited. For some, it may be quite extensive. Any pertinent history, and for ours we included some past medical history in terms of surgical history, hospitalizations, and some key significant social history as well. Current medications, any equipment needs, allergies, of course, and immunizations so that they can be continued on to the next practice. Luckily in DC we do have an immunization registry, but sometimes some practices don't have an up-to-date copy, and so making sure that the registry is updated as well. And then any special notes, so communication preferences. So for example, my patient with hearing impairment, they may prefer to be contacted by email, or our patients who prefer a cell phone versus a letter in the mail, etc. And we've been trying to do is sharing this with our young adults and their family, ideally before the age of 18, so we could start that process, and that they can then spread it to their providers. And we worked with our IT team within MedStar Health at Georgetown to kind of create this from our electronic medical record. And so some of the challenges that we had, though, it was a little bit time-consuming, having to meet with the information technology officer that works with pediatrics and trying to figure out what information we wanted to and how to extrapolate the information from the EMR. And it worked out well. It just took a couple of times going through and a few test runs and revisions, saying, no, I want a little bit of this, or we don't need this part, and trying to add things in. Trying, for example, like laboratories, and which labs would we want for the most current blood count or the most current, for our HIV patients, their most recent viral load to be able to be passed on to any future providers. Some of the issues that we have found is that some of our providers are not as good as others about updating problem lists and medications, and there can be duplications of diagnoses, and trying to really clear up the problem list and make it more fluid, so that way when we print out the portable medical summary, we don't have asthma 3 times with 3 different ways, asthma persistent, asthma intermittent. We can actually make sure that it's a little bit more consolidated. We also finding that our providers needed training and learning how to locate and generate the portable medical summary, and trying to teach the other docs in the practice and our nurse practitioners where to go to find this document. Our EMR in particular is a little bit cumbersome with a lot of checkboxes, and trying to find that tab. And then trying to learn how to disseminate that we're using it now to the other providers. And not just within pediatrics, but even our internal medicine or our family practice. We all share our EMR, and trying to just to let them know that this is now available and they can use this, because it's more applicable to any patient. It could be your patient who's moving across country, or your patient moving off to college. They can then have a portable medical summary. So some of our benefits that we find is that it improves understanding and self-care management. So when our patients actually see what their diagnoses are and their medications, and they can leave with that. Prevents some duplication of tests and procedures, so that when they do go to their next internal medicine appointment or family medicine, they know that they had that echocardiogram done 2 years ago, and they don't need it for another 3 rather than getting it immediately. This way that the youth and the young adults and or their guardians, if there are some issues of cognitive impairment, don't have to repeat information to multiple providers. So they actually have a written copy of everything, because they may not know every surgery that was done and what the dates were. That may be important, though, for future providers. Improves, obviously, then patient safety, which I know is a key concern for a lot of practices. It is in our institution, trying to prevent medical errors. And then obviously ensuring that our adult providers have accurate information.
My role tonight is to talk to you about care coordination and its role in healthcare transitions. And definitely, the first thing I will say is that our program would not have happened without the role, or without our care coordinators or our parent navigators. So I'll go through how they have really helped us. So care coordination, why is it important? Our care coordination definitely helps our families cope with the feelings and healthcare responsibilities in moving to a new system and new providers. Definitely there's a big hesitation from our parents and our families to talk about leaving our practice and going to another practice. And our care coordinators have been very helpful in talking to them about that. They also, of course, help our practice to be more patient and family-oriented. They build a team-based approach to care, and they create a lot of efficiencies within the program. As you see, there are different core elements that have to be that we need to get through. They definitely help us to link to other health and other related services as well. The care coordinator also reinforces the transition process within the practice. So they have been helpful for us in terms of going over the healthcare transition policy with our patients, with our parents, and with also other members of the healthcare team. They've been helpful also in terms of updating our registry. This is, and it depends on each practice. If there's, our practice is at least 5,000 patients, and half of them would be adolescents. You could just imagine the load that would be going into that registry. They've definitely been assisting with readiness assessment, from handing them out, from going over the parents and our families in terms of just going through what needs to be done. They've also been helpful in terms of clarifying the transition plan with us, other providers, and also with the parents and with the families. And they've been definitely very helpful in gathering key information for transfer. They're also been helpful in terms of communicating with the adult coordinator and provider, and being available for questions. And believe me, there's a lot of questions, even after meeting our parents and families for 1 or 2 visits, just talking about transition. In our setting, who are care coordinators, or the people who support our care coordinators, are parent navigators. The Parent Navigator program is started in 2009 at the Children's National Medical Center at the Goldberg Center, which is basically our community and pediatric health department. And it is built upon the family's need for peer-to-peer support, and also for their need to know different community resources, and also for guidance in navigating services. And we all are familiar to all these needs that our parents and families have, and it's particularly for our families who have children with special needs. So parent navigators, who are they? Usually they are parents of a child with special needs. So they are knowledgeable about the developmental disabilities that many of our children will have. And then they're very knowledgeable also with the healthcare delivery system. They have personal experiences dealing with the healthcare delivery system and different challenges that the system might have. And by their personal experience, they impart their knowledge to other families of children with special healthcare needs. So they've been very, because they have the experience, they have also the drive and the motivation to really be involved in this program. So how have our parent navigators been helpful in the implementation of our healthcare transition program? First, they've been the voice of the parents and families. They have been the people who have been helpful for us in creating the practice transition policy. We've gone through the policy with them. They've been helpful in terms of just disseminating it, talking to the other families and parents about if this is appropriate, if this is what you want in our policy, is this something that really will work, or is this something we need? They've definitely been helpful in implementing the practice processes to facilitate transition. And we've talked about the different core elements, and with each of the core elements, most of them, they've definitely been involved in it. They help maintain the transition registry, which is a very, very big part. They support our families and our parents emotionally and logistically through the transition process. And this, I think, for me, has been the biggest help that our parent navigators really have been doing for us. They maintain a library of community resources regarding transition, and they discuss the readiness assessment and the transition plan with progress with the parents. Besides myself or any of the providers talking to the parents and the families, they've also been there to talk about whatever action plan that needs to happen. And definitely they've been helpful in terms of what they've been doing also is coordinating the transfer of information to the adult providers. Definitely there are challenges. Definitely there's a challenge in terms of funding. We've been lucky for us over at Children's and definitely at the Goldberg Center that we were undergoing also our medical home certification, and part of that was also getting in our parent navigators involved. And part of that medical home certification, in case any of you are going through it or are planning to go through it, is that a part of that is transition. So funding them is going to be, funding care coordinators will definitely be a challenge. As I discussed a while ago, many of our parent navigators are parents of children with special needs. So they come from different backgrounds, and they're not necessarily social workers, or they're not necessarily in the healthcare system. So they've gone through training and just learning about care coordination, about HIPAA, about dealing with parents, where are the boundaries and all that stuff that, and there's ongoing training up to even ongoing training about transition, basically. And that's probably our third challenge because they have many roles within our system, and we've just put another role into their other roles, and that is to learn about transition. So hopefully that through what we're learning tonight and what we'll be learning through the next years and months of transition, that more training will be happening regarding transition. There's a lot of benefits from having care coordination. Of course, our parents, our families are definitely very satisfied with their visits. It's just better visit when our parent navigators are involved. Definitely parents are seeing the value of having teens take on more responsibility for their own care. And planning for a transition early is much better than waiting till the last minute for everyone. And that has been the biggest challenge we have right now. But definitely, if it started early and we're starting really to talk to them early, it's much, much easier. The earlier that families and youth learn about transition process, the more prepared they feel. And definitely comfort in having an organized transfer process in place and knowing that families feel more confident that information needs of their child have been adequately communicated to the adult provider is also a very, very big plus.